So first of all, I would like to thank the organizing committee, my friends, Dr. Selim Abdeslam and Professor Leila Abid for this kind invitation in this beautiful meeting. And I would like also to thank the scientific committee for the choice of the title of my presentation, Acute Coronary Syndrome, a monotherapy from the outset. From the outset means from the beginning of PCI, just some days or some weeks after PCI, facts or fakes. I have nothing to declare with this presentation. So let me start for saying that acute coronary syndrome monotherapy from the outset, according to the very last ESC guideline for the management of acute coronary syndromes, is fake. Because everybody knows that DAPT, aspirin plus clopidogrel or ticagrelor or prasugrel for 1 year is the current class 1 standard of care after DS. So I can finish my presentation here. However, there are many facts will be changed this class 1 recommendation in the future. The first fact, I think it's the advances of the new technology of DS, new generation, and I can say that stent thrombosis, a dramatic complication, is actually, it's nowadays a real problem. It's now a real problem in our clinical practice. Less than 1% of our patients will have a stent thrombosis, and we note a clear reduction in ischemic event also. The second fact, that bleeding event is harmful. It's very important to note that for patients after PCI, we will have a bleeding event, the 2-year mortality will increase by 5 times. And a new MI after PCI increase the mortality by 2 times. So it's very important to stratify the risk, the bleeding risk, and the ischemic risk before to choose the right strategy, monotherapy, or a long duration of the APT. The third fact, very important, that there is no additional antiplatelet effect when you add aspirin with a strong P2Y12 inhibitor, at least in vitro and ex vivo. And you can see in this study, in vitro study, when you add prasugrel plus aspirin compared to prasugrel alone, you can see no additional effect. The same thing with ticagrelor, aspirin plus ticagrelor alone, no additional antiplatelet effect. So the question, if aspirin doesn't seem to increase anti-aggregation, antiplatelet effect, do we really need it after PCI? In another word, can you use the aspirin-free strategy after PCI, or perhaps we need other alternatives? So we have a family of many trials, 7 trials finished and published, test this concept of monotherapy versus DAPT therapy, and all these studies use a duration period of DAPT for 1 month or 3 months for other study, and after we have monotherapy. All this study also included patients with acute coronary syndrome, and basically the result is similar for all studies. A significant reduction of bleeding event without any price to pay in terms of ischemic event, stent thrombosis, and cardiac death or cardiac mortality, or cause cardiac mortality. However, 2 important things to note. The first one is coming for STOP-DAPT2 ACS, included more than 4,000 patients with acute coronary syndrome, 1 month of aspirin plus clopidogrel followed by clopidogrel alone, compared to the standard strategy with aspirin and clopidogrel for 1 year. Again, a significant reduction of bleeding event, but with an significant increase of myocardial fraction. So the first message from STOP-DAPT, that clopidogrel monotherapy after only 1 month of DAPT appeared to be inadequate for most acute coronary syndrome. So important to choose the best agent and the best duration for the patient. The second message is coming from the very recent study, STOP-DAPT3, presented in the next ESC, last ESC at Amsterdam, a Japanese study, 6,000 patients. Sorry. So, prasugrel alone, aspirin-free strategy without aspirin just after PCI, compared to prasugrel plus aspirin. We obtained, after 1 month follow-up, no difference in terms of bleeding event. However, we note a significantly higher rate of stent thrombosis. So the conclusion of this study that aspirin-free strategy doesn't seem to be a good idea. However, it's very important to note the main limitation, the lower dose of prasugrel, 3.75 milligram, compared to our dose, the classic dose in our study. So we cannot extrapolate this result with our practice. And also the message, it's important to use the best agent and the best dose before to use a monotherapy strategy. So we are waiting for many other ongoing randomized trials with the same topic, but I think the most important study is a Brazilian study, Mindset. We use the aspirin-free strategy immediately after PCI, only prasugrel or ticagrelor. So in this study, we include patients with high-risk unstable angina, STEMI, non-STEMI, compared to aspirin plus ticagrelor or prasugrel versus ticagrelor or prasugrel alone, with a follow-up of 1 year. So this study will be present, I think, expected to be present at the next ESC in London. So meanwhile, we slowly see in this last ESC guidelines the entry of the 2A and 2B class recommendation for monotherapy, 2A for after 3 or 6 months of DAPT with, in patients with not high ischemic risk, and 2B in high bleeding risk patient. After only 1 month of DAPT, you can use monotherapy for this population. So my conclusion is that we can say that aspirin-free antiplatelet therapy with P2Y12 monotherapy after PCI seems to be a promising strategy. However, many questions remain to be answered related to the best agent, the best timing to start monotherapy, and also the right profile patient before to use this strategy. We are waiting for a number of going randomized trials to better understand the impact of the aspirin-free strategy, and perhaps we have other options. And this study, just 5 days before to switch aspirin with colchicine, you know that the inflammation plays a key role of the stent thrombosis, and perhaps colchicine, it's a possibility to use with ticagrelor or prasugrel, like in this study, a pilot study, 200 patients, and we can see that the incidence of stent thrombosis is only 1%. Thank you for your attention.